Anticoagulation Principles, Heparin, Part 2, Dosing and Side Effects. Hi again everybody, and welcome to the PharmEasy Tutor. In our last segment, we talked about heparin's mechanism, use, and kinetics. Today, in Part 2, we'll talk about dosing heparin and heparin side effects. To start off, let's discuss a couple of facts to remember about dosing heparin. Fact number 1, interpatient variability. The anticoagulant effect of heparin dosages can vary substantially from patient to patient. This could be due to heparin's binding to plasma proteins, macrophages, fibrinogen, lipoproteins, and endothelial cells after it enters the bloodstream. Because of this interpatient variability, heparin's anticoagulant response requires close monitoring, usually by measurement of the aPTT, activated partial thromboplastin time. Fact number 2, obesity. For the obese population, a BMI greater than 30 kilograms per meter squared, it is unclear if the patient's actual or adjusted body weight should be used to calculate the initial dose of heparin. This is because patients who are obese do not have a proportional increase in blood volume relative to weight. When calculating initial heparin doses for obese patients, dosing protocols can incorporate one of two strategies. Strategy number 1, doses are capped off at a maximum dose, for example 80 units per kilogram with a maximum dose of 5,000 units. Strategy number 2 is to use adjusted body weight when the BMI is greater than 30. Adjusted body weight is equal to the ideal body weight plus 0.4 times actual body weight minus the ideal body weight. Let's first talk about the initial dose for heparin. Heparin therapy is initiated with a weight-based IV bolus dose followed by a weight-based continuous infusion dose. Therapy is monitored using the aPTT, and the heparin drip rate is adjusted based on the lab results. Here is a table with some examples of initial heparin dosages based on indication. For VTE, which is DVT or PE, the initial bolus dose is 80 units per kilogram with an initial infusion rate of 18 units per kilogram per hour. A lower dose is used for acute coronary syndrome, unstable angina or non-STEMI, with an initial bolus dose of 60 to 70 units per kilogram, followed by an initial infusion rate of 12 to 15 units per kilogram per hour. Similar doses are used for STEMI patients who have received full-dose TPA. Dosing recommendations may vary depending on the indication and the degree of desired anticoagulation. For example, ACS or stroke doses are much lower due to an increased risk of bleeding. Each institution should adopt their own individual initial doses based on the desired intensity of anticoagulation for each indication and the characteristics of the population they treat. What about the maintenance dose? Let's talk about that. After infusion is begun, the aPTT should be measured after 4 to 6 hours. Based on the aPTT result, the heparin rate should be adjusted upward, downward, or kept the same based on the protocol. Here's a question. Why do we wait 4 to 6 hours to measure the aPTT? Here's the answer. Heparin half-life is 60 to 90 minutes, or 1 to 1.5 hours. It takes 4 half-lives to reach steady state. Therefore, it will take heparin 4 to 6 hours to reach steady state and to reach its therapeutic effect. Dose titrations of heparin continue, and adjustments are made every 4 to 6 hours until 2 or more aPTT values in the therapeutic range are obtained. Then aPTT is checked daily. How do we determine how much we need to adjust the heparin infusion rate? We will usually follow a heparin protocol. Numerous heparin dose adjustment nomograms have been developed and can be readily found on the internet. Here's a good example of a heparin protocol that I selected off of the internet from the University of Washington. You can see that the protocol has both a regular intensity and a low intensity protocol. Today we're just going to be focusing on the regular intensity protocol that has a aPTT goal of 60 to 100 seconds. You can see, as stated in the protocol, that if the aPTT is in the therapeutic range of 60 to 100 seconds, no change in the rate should occur, and the aPTT should be rechecked after 6 hours. If the aPTT is below 60 to 100 seconds, this means the patient is subtherapeutic and requires additional heparin. This is given as a bolus and increase in infusion rate in various amounts depending on the aPTT result. Likewise, if the aPTT is greater than 60 to 100 seconds, this means the heparin infusion rate has to be decreased and possibly held for a short period of time. In both cases, the aPTT is checked again after 6 hours. If the aPTT result is greater than 200 seconds, this means too much heparin has been given, so the infusion needs to be stopped temporarily. It can be restarted after the aPTT decreases to 100 seconds at a rate lower than 4 units per kilogram per hour than previous. As a side note, you can compare the low intensity protocol goal to be less than the regular intensity, targeting 60 to 80 seconds. Here's a very important note. Remember that these nomograms are specific to the institution, and these protocols apply only for their patient populations. They should not be used generically. Let's talk about the heparin dose for VTE prophylaxis. Prophylaxis of VTE using sub-Q heparin is a safe and effective method to reduce the risk of venous thromboembolism in medical and surgical patients. Low-dose heparin reduces the risk of venous thrombosis and fatal PE by 60 to 70%. The dose is heparin 5,000 units sub-Q every 8 to 12 hours, or 7,500 units sub-Q every 12 hours. Heparin 5,000 units sub-Q every 12 hours may be considered in low to moderate risk patients, elderly, or low-weight patients. What about the heparin dose for catheter flush? Heparin can be used as lock flushes to instill in central line catheters in order to maintain catheter patency of indwelling central venous catheters. It can be used in ports at a concentration of 100 units per ml and a volume of 3 to 5 mLs. It can also be used in PICC lines or midline lines at a concentration of 10 units per ml with a volume of 3 to 5 mLs. Always be sure of which concentration of heparin you're using, either 100 unit per ml or 10 unit per ml. Remember, heparin is a high alert medication where errors can be made. The aPTT is a commonly used lab value, but it does have its drawbacks. Let's talk about some of them. The aPTT, reported as a clotting time in seconds, is the most frequently used laboratory test to monitor the anticoagulant effect of heparin. The test is convenient, automated, and relatively inexpensive to perform. Since the 1970s, therapeutic anticoagulation was defined as an aPTT value that was in the range of 1.5 to 2.5 times the control value. This target range corresponded to a heparin level of 0.2 to 0.4 units per ml and was associated with a reduced risk of thromboembolism. Thereafter, the practice of setting this range as the therapeutic goal gained wide clinical acceptance. However, in the past 25 years, the reagents and instruments used to determine the aPTT have changed. Today, there are more than 300 laboratory methods in use, as well as greater than 30 reagent combinations used in the United States. Depending on the reagent and coagulometer, aPTT results can range from 48 to 108 seconds in samples with a heparin concentration of 0.3 units per ml. So the different commercial aPTT reagents and instruments vary in their responsiveness to heparin. Thus, there is a wide variation in aPTT results among different laboratories depending on the lab method employed and on the reagent sensitivity to heparin unique to each laboratory. Accordingly, a hospital's target aPTT can vary depending on which laboratory reagent is used for their testing. Furthermore, the term control value is poorly defined. The control can be interpreted in various ways: as the patient's baseline prior to treatment, the average aPTT in healthy volunteers, or the value of the normal range for the aPTT at the health system. Numerous heparin dose adjustment nomograms have been developed, but none are applicable to all aPTT reagents. Therefore, the therapeutic aPTT range at each particular institution should be tailored to the responsiveness of the reagent and coagulometer used. The College of American Pathologists and American College of Chest Physicians recommend that the therapeutic aPTT range be calibrated specifically for each reagent or lot coagulometer by determining the aPTT values that correlate the therapeutic heparin levels. There are two other laboratory values that are used to monitor heparin's effect. One is called anti-factor Xa, and the other one is called the ACT. How does the anti-factor Xa heparin assay compare with the aPTT? Therapeutic heparin levels correspond to an anti-factor Xa activity of 0.3 to 0.7 units per ml. The anti-factor Xa assay may have greater accuracy than using aPTT in the monitoring of heparin, as it is a more direct measure of heparin activity. Over the past years, this assay has become more automated, and an increasing number of U.S. hospitals are transitioning to it for clinical practice. Here is an example of a protocol-driven titration of heparin based on anti-factor Xa levels from the University of Washington. The regular intensity therapeutic goal for anticoagulation is an anti-Xa level of 0.3 to 0.7 units per ml. The infusion is increased, decreased, held, or kept the same depending on the anti-Xa level result, much like the heparin protocols that we saw previously. What is different about the ACT, or the activated clotting time? The ACT is a point-of-care test which makes testing at the bedside more convenient with a quick turnaround. It's less sensitive than the aPTT. It's used when patients are receiving high doses of heparin. This is used during cardiopulmonary bypass, ECMO, or during PCI. Let's move on and talk about heparin side effects. Heparin side effects include bleeding or hemorrhage, with an incidence of 1.5 to 20%. The risk of bleeding is related to dose intensity of treatment. Concomitant bleeding risks include recent surgery or trauma, invasive procedures, hemostatic defects, age greater than 60 years, and worsening hepatic function. Heparin can also cause allergic reactions, which are rare. Hypersensitivity reactions with chills, fever, pruritus, urticaria, asthma, rhinitis, lacrimation, headache, and nausea and vomiting. It can also cause elevated liver function tests. Significant elevations of the AST and ALT have occurred. These elevations are usually transient and typically resolve upon heparin discontinuation. Other side effects with long-term use of heparin include alopecia, suppression of aldosterone synthesis with hyperkalemia, and osteoporosis and vertebral column fractures. Osteopenia is caused as a result of heparin binding to osteoblasts, which then release factors that activate osteoclasts. Heparin-induced thrombocytopenia, or HIT, is a hypercoagulable disorder with approximately 1/2 to 1/3 of patients developing thrombosis. The incidence of HIT ranges from 0.1 to 5%, with 35 to 50% of these patients developing thrombosis. HIT is not dose-related. Primary clinical presentation of HIT is a greater than or equal 50% decline in platelets, or a platelet count less than 150,000. Risk factors of HIT include duration of heparin therapy. Unfractionated heparin has a greater chance than low molecular weight heparin. Surgical and trauma patients are at a higher risk compared to medical patients. Females have a greater risk than males, and patients who have advanced age. There are two types of HIT. Type 1 is called heparin-associated thrombocytopenia. It occurs within 2 to 4 days in a heparin-naive patient. The severity is benign and mild, with the platelet count dropping rarely below 100,000. It's non-immunogenic, the drop is temporary and will recover, and it resolves without stopping heparin. The second type of HIT is called type 2, heparin-induced thrombocytopenia. This occurs within 5 to 10 days in a heparin-naive patient and reaches a threshold by days 7 to 14. The severity is serious, with the platelet count progressively falling or decreasing by greater than 50% or to below 100,000. It is immune-mediated thrombocytopenia, and 1/3 will develop thromboembolic complications. Let's go over the mechanism of HIT. Here is a picture of a platelet. Surgery or infection causes activation of platelets to secrete a protein named platelet factor 4 or PF4. Heparin binds to the protein PF4, a cationic protein, on endothelial cell membranes. This binding neutralizes heparin and limits its anticoagulant effect, thus promoting coagulation. Because of its large size, the heparin PF4 complex is highly antigenic, causing an immune-mediated reaction that induces formation of IgG antibodies against it. This results in the formation of the HIT antibody. The HIT antibody, consisting of heparin, PF4, and IgG, then binds to platelet receptors, leading to platelet activation. Platelet activation will lead to platelet aggregation. This prothrombotic environment with a low platelet count can lead to severe thrombotic events that can include pulmonary embolism, DVT, stroke, MI, gangrene, limb amputation, or death. Platelet activation can also cause the release of procoagulant microparticles, which can also cause thrombosis. Platelet activation can also lead to further release of PF4, which propagates the HIT cycle. Platelets are also removed from the circulation by splenic macrophages. They are consumed, leading to thrombocytopenia. Treatment of HIT. The primary drug that we use for HIT is argatroban. Argatroban is an IV direct thrombin inhibitor. The dose for HIT is 2 micrograms per kilogram per minute continuous infusion. For moderate or severe hepatic impairment, we need to start at a lower dose of 0.5 micrograms per kilogram per minute. Adjust the dose as necessary to obtain a steady-state aPTT in the target range of 1.5 to 3 times baseline values. Some clinicians advocate initiating therapy for all patients at a more conservative lower dose of 0.5 micrograms per kilogram per minute and reducing the dose for hepatic impairment to 0.25 micrograms per kilogram per minute. Off-label drugs used to treat HIT include fondaparinux, which is a factor Xa inhibitor, and DOACs, which can be given orally, such as rivaroxaban, 15 milligrams twice a day for 3 weeks if thrombosis is present, 15 milligrams BID until platelets recovered to greater than or equal to 150,000, and then 20 milligrams per day. Complete platelet recovery is seen in approximately 65% of patients within 1 week of heparin cessation. Thrombotic risk remains high for 4 to 6 weeks after diagnosis. The 30-day risk for thrombosis after heparin withdrawal is estimated to be between 19 and 52%. Unfractionated heparin versus low molecular weight heparin, which has a higher incidence of HIT. HIT is less likely to occur with low molecular weight heparin compared to unfractionated heparin. A minimum of 12 to 14 saccharides are required to form the antigenic complex with PF4, so unfractionated heparin molecules with a molecular weight greater than 4,000 Daltons have the highest potential to cause HIT. Let's summarize what we learned in Part 2. In Part 2, we described how to dose heparin using established weight-based protocols. We explained the limitations of using aPTT when monitoring heparin, and we listed the adverse effects of heparin and keyed in on heparin-induced thrombocytopenia. Coming up next in Part 3 of this 3-part series on heparin, we'll explain the differences between unfractionated heparin and low molecular weight heparin. We'll describe how to treat overdoses of unfractionated heparin and low molecular weight heparin with protamine. We'll review the pharmacology, kinetics, and side effects of enoxaparin, and we'll list enoxaparin's indications and respective dosages. So stay tuned. Thanks for tuning in to watch this installment of the PharmEasy Tutor. I hope you learned something that you could use at school or in practice. If you'd like to continue to see more of these types of tutorials on YouTube, please make sure to click on the subscribe button below to change it from red to gray. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to blue. If you have any comments or questions, please feel free to add them in the comments section below, or share this site with someone else. Stay tuned to the PharmEasy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.